Yes, so it's 3, 2, 1. We are on it to the audience. We can start the session. Over to you, sir.
Good evening. On behalf of the Tamil Nadu Ophthalmic Association, as the president of the Tamil Nadu Ophthalmic Association, I have great pleasure in welcoming you all for this 9th TNOA ERC PG Masterclass. As you know, TNOA has been really shining, and the theme for this year is Tamil Nadu Smiling and TNOA Shining, and we are doing exactly that for the past 7 months. Since I took over as the president of Tamil Nadu Ophthalmic Association in September 2021. We have been having a series of programs. The first Friday of every month will be the first Saturday of every month. We have the Walk the Talk series, which has become very popular with the luminaries of the TNOA. And this Walk the Talk series, the main objective is to get inspired, motivated, and rejuvenated. And we've been having really top-class luminaries of the Tamil Nadu Ophthalmic Association in this Walk the Talk series. On May 7th, that is next Saturday, we're having with none other than Dr. T.S. Surendran, Vice Chairman of Shankar Nethralaya, in the Walk the Talk series. And we're looking forward to it. Apart from that, we have the TNOA ARC PG Masterclass, which is on the second Friday of every month. This is an exception because we wanted to accommodate the refractive surgery masterclass also. And we have none other than Dr. Anand Parsadi, who is a master himself in the cornea and refractive surgery. And he was trained in SNEC, and he's been a real, what he calls stalwart as far as the refractive surgery and corneal surgery is concerned. And he is going to be the course director for this master class on refractive surgery. And all these master classes on every subspecialties of ophthalmology is being moderated by none other than our dynamic chairman of the ARC of Tamil Nadu Ophthalmic Association, Professor Dr. K. Raj Shekhar, who has been really instrumental and pivotal as far as the master classes is concerned. The TNOA ARC PG Masterclass is being supported by the Milmet. I'm very thankful for them. And also, we should understand that this TNOA Masterclass is one of its kind. Because every time we have a masterclass, we have a huge number of people, delegates, not only the residents, the postgraduates, but also the practicing ophthalmologists logging on to the TNOA YouTube and the Facebook as well. Apart from that, in the last month, this month, that is the month of April, we had a very unique program under the TNOA, which is called the Gurukulam TNOA. As you know, Gurukulam means teaching and imbibing knowledge. And every Sunday, in the past 4 Sundays of April, starting from April 3rd, 10th, 17th, and 24th, we had 19 faculty across India covering about 26 topics in length and breadth. And it was a huge hit because all the people, all the delegates were on the Zoom. It was like a physical class, and it was a one of its kind, and it was a very grand success. I'm very thankful to Dr. D. Chandrasekhar and Dr. V.R. Vijayaraghavan of Coimbatore for leading this Gurukulam TNOA, which has become a real gold standard for ophthalmic teaching in this part of the country. Apart from that, TNOA is also very active in what is called the TNOA Connect series. And every last Sunday of every month, we are having the Connect series wherein we're connecting all the major institutions across Tamil Nadu. Like Shankar Nethralaya, Arvind Eye Hospital, Shankar Eye Hospital, the Eye Foundation, Rajan Eye Care, Uma Eye Clinic, and so many other, Arasan Eye Hospital, and so many other hospitals, because as you know, Tamil Nadu is the mecca of ophthalmic education and teaching in the entire country. people from all over the country come to Tamil Nadu for their ophthalmic postgraduates and also the residency programs, because we have got the gold standard institutions here. Now we wanted to connect everybody, and that is the idea of the connecting, communicating, and consolidating the knowledge as far as ophthalmic education is concerned. And we have been covering every subspecialty of ophthalmology in this also. But this Connect series is totally different from the masterclass. In the masterclass, the main objective is to take 1 or 2 topics which will be useful for the postgraduates when they go for the exams. And we have Dr. Anand Parsadi, who is going to take us through this masterclass, an entire gamut, and of course, the 2 national faculty. I don't have to have they don't require any introduction. Dr. Amos Ravindra is a stalwart in anything. You take it from the anterior to the posterior segment. I have seen him doing everything in ophthalmology as far as eye is concerned, from the front to the back. And everything, he excels in whatever he does. Whether it is an SICS or a phaco or a glaucoma surgery or a vitrectomy or a squint or an oculoplasty, refractive, Amos Ravindra is probably the best. And you can't get better than him anywhere. And he runs his own hospital, Karthik Netralia, which is really a fantastic hospital. And I've been associated with Dr. Amos Ravindra as one of the earliest fellows of Shankar Netralia. And I've learned a lot from him as well. For people who do not know, the recently in American Academy of Ophthalmology, just 2 days back, his phaco section, which is a novel technique for hypermature cataract, the small incision cataract surgery, has been featured in the American Academy of Ophthalmology website. And it's really a fantastic video, a video which inspires and motivates all of us. I'm very thankful to Dr. MSR, sir. Thank you very much for being here with us. And of course, Dr. Swapna Nair. She also doesn't require any introduction. And Swapna Nair becomes young every year. She doesn't become, all other people become old, but Swapna is always the evergreen. They run the huge chain of hospitals in Kerala, the Chaitanya Eye Group, Eye Institute Group, which is doing extraordinarily good work. And she is an expert in cataract, cornea, and refractive surgery as well. I'm very thankful to both of them for having joined here. And of course, Sujata, who is an expert in refractive surgery, who is here as a panelist as well. So over to Dr. Madhuban, the secretary of TNOA, who has been doing tremendous work. I always call him the unsung hero, a guy who is really one of the pillars, if not the foundation of TNOA. Tremendous work he's been doing for the past almost 4 years now. And Dr. Madhuban to say a few words, and then after that, Dr. Raj Shekhar will take over.
Thank you. Thank you, dear President, for your kind words. Dear President, Dr. Mohan Rajan, our dynamic ARC Chairman, Professor Dr. Raj Shekhar, our Joint Treasurer, Dr. Manoj Vasudevan, the masters of the day on the occasion of knowledge sharing in refractive surgery, on the occasion of TNOA ARC PG Catalyst Masterclass Program, the 9th edition since September 2021, which is going in a clockwise precision as envisaged by our President with his 10 commandments when he took over at Chennai last year. Incidentally, the next conference at Coimbatore has our Best Free Paper Award for refractive surgery in the name of Dr. Sundaramurthy sir. And on this occasion, I think it's a apt moment to recall his services also. Our TNOA membership updation, data updation is going on, and I would request our members to give support to our association by making any necessary changes in the data by writing or emailing or WhatsApp to our TNOA office. And in the same vein, the AOS elections or has been, dates have been announced. It is from 21st May to 28th May. It's an exclusive online election. And we all know that our dynamic president, Dr. Mohan Rajan, is contesting for the post of Vice President AOS. And it's our responsibility and duty to enthusiastically participate in that election and make our dreams come true. And of course, AOS will then be shining like TNOA is shining. Thank you, sir. Thank you for this great opportunity.
Thank you, Madhuban. I'll be failing in my duty if I don't mention the name of Dr. Raj Shekhar, of course, I mentioned, and also Dr. Manoj Vasudevan, Joint Treasurer of TNOA, and he's been coordinating this program along with Dr. Anand Parthasarthi. I think we should all give a big round of applause to Dr. Manoj Vasudevan, who's been really tirelessly working for this webinar, as well as the next webinar, also Connect series we are doing with Joseph Eye Hospital on ocular trauma on May 15th. So over to Dr. Raj Shekhar, the chairman ARC and the moderator for this session, and he will take over.
Vanakkam, sir. Vanakkam to all. What do I have to say? With the help of our president, Dr. Mohan Rajan, our secretary, Dr. Madhuban, and all office bearers of TNOA, we feel proud that we could create this brand called TNOA ARC Masterclass. This brand is in its 9th version today. And I was just feeling, as Mohan Rajan sir was introducing the session, I was just feeling in my heart, which session is better? Each session is rivaling each other. And in fact, last session we had Dr. Pradeep Sharma speaking to us. And this session we have none other than Dr. Amos Ravindra speaking to us. And it's a honor, it's a privilege. And the only work TNOA ARC is doing is to be like a vehicle connecting these marvelous teachers to the huge repertoire of students in different sets of institutions. We see students across the country in different levels of institutions where they would have access to multiple gadgets and multiple technologies and multiple procedures. And in that way, when they mature up as consultants, as young consultants, it is our duty as senior ophthalmologists to see to that they have a wholesome view of everything that is happening in ophthalmology, and that is the in thing in ophthalmology. And what else is the in thing than refractive surgery as on date? And I am privileged to introduce Dr. Anand Parthasarthi, our master trainer, our very own Dr. Anand Parthasarthi, who is very popular with the young ophthalmologist community for his presentations on refractive surgery. And we are honored and privileged, as I told, to have Dr. Amos Ravindra. Sir will be speaking to us on advanced surface ablation. In fact, I will be your first student, sir. I want to see all the advanced surface ablations you want to teach us. And none other than Dr. Swapna Nair. I had been to Kerala recently for the occasion they arranged. And I was so very much moved by their hospitality and the arrangements they had. And from Dr. Swapna, we are going to listen about femto concepts. And to moderate this, we have Dr. Sujata Mohan with us. Madam will be able to catch the threads which these teachers are going to leave and make more knots out of those threads. And the home rules are Dr. Manoj, my co-moderator, will be introducing the speaker for the benefit of the audience, because these teachers are so very exemplary. They don't need any introduction in my way of looking at it, but for the benefit of an average student, we want them to be formally introduced, and Dr. Manoj will be doing that honors. And then the teachers will be speaking for 20 to 25 minutes about their topic. And then all the students who have been logged in will be having a chance to type in or key in their queries and questions into the chat boxes. In multiple social platforms, we are today hosted. And when we get those questions, when those questions are got to us, we'll be voicing them to you. And the panel discussion can go for 10 to 15 minutes. Time will not be a big constraint in this session, but the reaching out for students will be. I think the basic sentiment which Masterclass conveys is it tries to teach students who might not even know the ABCD of what is being spoken. So if that sense and sentiment is conveyed, I'll be the most happiest person. With that, I will request Dr. Manoj to first introduce Dr. Anand Pardasari.
Thank you very much, sir. So, today's master class on refractive surgery, the postmaster is none other than our own TNOA popular Dr. Anand Pardasari. So, the postmaster will be Dr. Anand Pardasari. So, I request him to say a few words before introducing Dr. Amos Ravindra, sir, to start his first talk. Dr. Anand Pardasari, sir.
Sure. Actually, when Manoj called me almost about 5 months back, when Dr. Mohan suggested, and I was really amazed. I said, no, he's thinking so back long, and we were trying to see how to actually make it acceptable. And there was an emphasis from Raj Shekhar, from Mohan, from Manoj, saying that it needs to be super basic. It needs to be something that postgraduates can relate to, and that I totally agree, because as a postgraduate and even training in the best of institutes, refractive surgery is like a hallowed platform where you look but you can't touch. So that's something that I realized is important, that you at least break the myth that the principles of ophthalmology are same across all super specialties, either cataract, retina, cornea, or even refractive surgery. And I wanted to reach out to people who can simplify it. And it is my honor to actually invite both Dr. Ravindra and Dr. Swapna, who I have learned from so much, not only in practice, but also in terms of life. So I would not really delay anything more. And I'll request Manoj to introduce both Dr. Ravindra and Dr. Swapna, and we can start the scientific session.
Thank you, sir. So there's no introduction needed for the stalwart of the first speaker, Dr. Amos Ravindra. It's a great pleasure and privilege and honor to introduce him. He is the chairman and medical director of Karthik Netralaya, Bangalore, and is a managing trustee of Netra Jyoti Foundation. He's been the recipient of many Oration Awards and is an invited speaker and faculty of almost all the national and international conferences. So, sir, you can take please, we are inviting you to present your slides, sir.
Thank you, sir.
Yeah, thanks to our president, Dr. Mohan Rajan, and office bearers of TNOA. Is my screen visible or?
Yeah, put it in the slideshow, sir.
Fine, slideshow.
Screens
How
are
about
visible.
now?
Yes. Yes,
Fine.
sir.
Fine. So it's like for me coming back home, and I thank Dr. Mohan Rajan and all the office bearers of TNOA, Dr. Sujata Mohan, panelist, and moderators, Dr. Raj Shekhar and Dr. Manoj, and more than all, Dr. Anand Pardasari, who invited me to participate here in this program as a as a speaker. So with very great humbleness, I would like to present few thoughts of my experience in last 2 decades of what we did with the LASIK. We got introduced to LASIK way back about 22, 23 years ago. That's plus 22 decades. And to begin with, it was LASIK. But when I started doing LASIK at that point of time, the corneal flap that we took was so thick, it was like a rubber piece. And going back, it was beautiful. It used to sit back, but very soon we started seeing complications of the ectasia and all those things. At that point of time, about 20 years ago, I thought of why not we do the PRK instead of raising a flap. We had one of the best flap making machine, that's Amadeus. But am I audible?
Yes, sir, you're audible.
Fine. Very much audible, Ravindra.
So to go back historically, it is in 1988. Imagine a person who is looking at prescribing glasses in 1988 has got a strong weapon to correct that refraction. That was by Dr. Munarlin. It's a very, very famous name in LASIK, and he presented his technique of photorefractive keratectomy, a technique for laser refractive surgery in JCRS journal in 1988. So very soon, in about 7 years' time, it got the FDA approval, and it was being done in many, many centers all over. Excellent machines were available, but they were all broad-based LASIK machines at that point of time. But what happened was when you remove the epithelium basement membrane and Bowman's membrane and a little bit of stroma, there is an injury component. The post-operative pain was severe. The patients all were, literally crying. Visual recovery was not instantaneous. It used to take weeks and months. And there is a complication called stromal haze, which came up after doing a PRK, photorefractive keratectomy. That's done with the excimer laser. And then that's the reason to avoid the pain, to have the wow factor, to have the improvement in the vision immediately, and to avoid the complication of haze, LASIK was introduced and it was approved by FDA in 1998-9. That's the time we bought our machine, and that's the first wave light machine in the whole country. So a cornea was sliced on the surface. You raise the flap instead of doing the laser on the surface. You raise the flap and do it on the anterior stromal plane after raising the flap. And then are we got rid of all the complications? Not really, because when you put the flap back, you're not going to stitch it up like a keratoplasty, and that flap which sits back can be raised at any point of time. We have raised flaps 3 years later, 5 years later. The bed and the flap will never heal. The flap is redundant. Once you raise the flap, you put it back, it gives an anterior surface, but it does not add to the strength of the cornea. Imagine you have a cornea which is 500 microns. You raised a flap of 150 microns and put it back. You're not done laser. The cornea no more has a strength of 500 microns. Its strength now is 350 microns because you raised a flap. It will never heal. So we came up with ectasias. We came up with flap-induced aberrations, because once you raise a flap, when you put it back, you cannot put it back just like what God made it. So there used to be some amount of misalignment between the two, and that can give rise to a lot of aberrations. So now we are looking at going back to advanced surface ablations, going back to PRK. That's about 1988 to now, about 3 decades time, we are going back. So they say the science, the fashion, everything goes around wheels, and that's what we're going to do it. Excimer laser is short of, for postgraduates, it's a short of excited dimer. There's a lot of science behind it. Kindly go through the literature. LVC stands for laser vision correction. Any procedure that's corrected by laser is called LVC. That's a short name. In excimer laser, you use argon fluoride gas, 193 nanometer, just like in an X-ray tube, there is an argon fluoride tube which emits 193 nanometers. It's an UV light. UV light, when it touches any tissue, it melts it there. So it melts, it dissolves. So there are two kinds of technology. One is broad beam. The beam itself is very large, so that it's a heavy, big machine, big beam, and it comes and titrates it, and you can vary the amount of titration depending upon the apertures. The aperture blocks laser. The aperture can widen and shorten depending on what you want, where you want. And today it's all the game of slit scanning laser or flying spot laser. Slit scanning is popular with a machine called NIDEC. Flying spot laser, most of the other machines today, they work on flying spot. I'll briefly explain what is flying spot in a short while. There are two kinds of treatment. One is you do it on the surface. That's what I was trying to say, where there is no stromal flap. Okay, and the photorefractive keratectomy is what I said. Then you have a LASIK. Then you have an epi-LASIK. I'll explain in a few steps. And two-step trans-PRK, you do a PTK to remove the epithelium. If that's a cornea, the epithelium can be removed by varied ways. In epi-LASIK, you use an epitome. It's a machine with a blunt keratome which goes, I'll show you a video. It removes the epithelium. And in LASIK, you use alcohol for that. Two-step trans-PRK is you use PTK mode, phototherapeutic keratectomy. That is what you use to remove the scars. It removes the parallel layer of cornea. So that can be utilized to remove the epithelium, which is about 50 to 60 microns. PTK, you remove the epithelium with the laser, then you go to the stroma and you correct the refractive error. PTK followed by PRK is two-step trans-PRK machine. While today, the machine itself is programmed. You can do a PTK of whatever you want initially, that removes the epithelium, then you go ahead and do the PRK or the LASIK, which corrects it. So you remove the epithelium with the same machine, same argon fluoride laser, followed by the surface ablation by the excimer laser. While when you raise a flap, you weaken the thickness of the cornea. The standard procedure with LASIK, where microkeratome is a vegetable peeler. You take a carrot and peeler. Same way, the same philosophy. You have a peeler called microkeratome, which raises a flap. The thickness of the flap can be 100 microns, 110, 130, 140. We can vary it depending upon the different heads, and that raises the flap. You treat the bed and then put the flap back. That's LASIK. Instead of the microkeratome, use a femto laser. So that's another machine itself. You put the patient on the femto laser, you raise a flap and shift to the examiner laser and ablate the tissues. So in both of them, there is a flap that is raised. In a smile, it's a beautiful technique where you don't have to raise a flap, but you create a pocket. I think Dr. Nair is going to tell us more about that, and I'm keenly opening. As I said, the flap can be opened up any time in the future. That's a broad beam laser, and you in the edge of it, you can see this is a cross section, and there is a sudden cut there to the periphery in the treated area and untreated area, and that never gave a very good treatment profiles. And moreover, today there are a lot of advancements in the laser. One of them is the flying spots. The flying spot is, these spots come at a very high frequency, 500 times in a second, 500 times in a minute. So this can go around and treat very fast. I mean, there's no repetitiveness. It remembers the surface. This laser hits here, it hits here, it hits there, it hits there, and try and make a Gaussian saucer-like opening. And that's the kind of technology that's used now for both LASIK as well as the EpiLASIK. PRK, you have pain, you have haze, you have scars, and poor ablation pattern. While in ASA, because it uses modern flying spot laser, ASA stands for Advanced Surface Ablation. The laser width of every beam depends upon the machine. It can be anywhere from 0.56 to 1 millimeter. It's got that Gaussian beam profile so that it gives a very smooth surface at the top of it. We can modulate the wound to avoid totally the scar by using modulation, mitomycin, and we can moderate the pattern of surface ablation. See, cornea is like a fingerprint. It's never even. One cornea of the right eye and left eye cornea may be different, and the power may be same, -3 in 5 people, but every cornea is different. The machine today can understand the pattern of the topography and can adjust the ablation depending upon the topography. That's called topographic optimization or wavefront optimization. That's a possibility, and that is best done on the surface. Imagine you raise a flap, do the pattern correction, and then put a flap back, and the pattern correction is in tunes of 1, 2, 3 microns. That's the level that of treatment changes that it does for the surface. And when you put a flap back, everything is diluted. So the best topographic optimization or wavefront optimization is done on the surface, not under the flap. This is our statistics of last 814 eyes. As you can see, we have initially started with LASIK, but we have switched out to ASA in majority of the patients. 63% of our surgeries today is even more, are done on the surface. Only about 27% is done with either femto or thin flap LASIK. So the femto is, though we have one of the beautiful machine, we use it much less often. So if you look at the power correction, under 6 diopters, you have a 66%, 2/3 are done under 6, but we have a large percentage of cases done on surface for powers more than 8 diopters. As you can see, 10 diopters and more, there's a huge surface of addition of sphere and cylinder. We have 30 eyes. So that's a very large number of very high power. That means it's not that surface ablation is only meant for very low powers. What are the special indications? I would say any eye that needs a laser should be treated by surface ablation, not by cutting the slice in the cornea. But in addition to that, if somebody has got all the facilities, wherever the residual bed thickness, you remove the flap, you ablate it, what is left behind in the cornea without the epithelium is 300 microns. That's a cutoff point. You should not, internationally they say 250 microns bed is all right at the end of treatment, but we take it 300 microns as a cutoff point. If when you calculate the amount of stromal bed that's left behind is less than 300 microns, I would prefer an surface ablation. For flat or steep corneas, when the corneas are flat, steeper than 48 or flatter than 41, I would recommend ASA. Dr. Anand, you'll have to tell me when to stop. So otherwise, this will keep on going on.
So there
I
is
can stop it at
absolutely
any
no
point of
problem.
time.
No problem,
Absolutely.
sir. You can take your time, sir.
Fine. Whenever there is a surface inflammation, it can be dry eye, it can be epithelial basement membrane dystrophies, recurrent, any sign that indicates there is an active inflammation on the surface, the LASIK, and if you still want to do laser vision correction, the best would be advanced surface ablation and not a flap. Okay, and then whenever the patient, you have to ask the sports what kind of activity the patient has. He has got a tendency to hit himself in the eye, like he's he plays cricket or whatever it is, and there is a possibility of injury in the future. Then surface ablations are better. And technically, when all of us know that when the eye fissures are very small, mongoloid, whatever it is, and deep orbits, it's very difficult to put a microkeratome there and or femtolaser cone there, and there again surface ablations are preferred. So the what is the advantage? There is no flap related complications at all. If you look at any LASIK, the complications, flap related complications constitute a majority of them, and there is no flap related one stroke you're going to remove everything. No risk of flap induced aberrations. As I said, you cannot put the flap back exactly like what it was before, so that would cause aberrations. We are all aware of it. It's eliminated. So these are the advantages. So any patient coming for laser, we should not take him for laser unless we exactly know why is he looking for laser vision correction. So I have refused more lasers. So in our setup, if 100 people come to our setup asking for it, about 30-35% we just refuse. Psychological reasons, eye checkup reasons, whatever it is, he should convince us that he needs a laser vision correction, and he'll be happy after that. So you'll avoid a lot of headaches. Detailed eye checkups, discontinue contact lens for as long as 2 to 6 weeks. If you're an RGP or if it's a toric contact lens, don't use contact lens for as long as 6 weeks time. Nothing happens. The patient will come back again to you. And topography has to be stable at the end of that picture. Investigations, you're all aware of it. We have all the gamut of reactions. What is often missed is pupillometry. Many people who are unhappy, especially if they're professional drivers, if their pupil size is 5 millimeters, 6 millimeters, 7 millimeters sometimes, mesopic or scotopic pupil size, and you do a LASIK on them, he's never ever happy. So you should know what is the size of the pupil. Pupil size can be measured on ARK machine itself. Put a hood on him and measure it, take a photograph of the screen, or we have what we call the OPT3 scan, which can give pupil size very accurately, mesopic and scotopic. And all of us should do a biometry on these patients. Why do we do biometry? We are not going to put an implant there. The patient comes back with a regression after 2 years' time. You made it 0, the patient comes back with -2 power. There is a regression. He has got back the score. He'll start fighting with you. You assured everything, but why did I get the power back? The biometry will tell us if there is a change in the biometry at that point, and we can tell him there is an axial growth of the eye, and that's why you got the power. So it's very important to have it. Specular microscope, we do it in every patient, and Shermers, they are necessary, and blood tests are essential. Though they are all young, we have seen diabetics, we have seen rheumatoid arthritis, we have seen all kinds of ESR is high in some people. All that, that applies to all the LASIKs. What do we do before surgery? We definitely put them on antibiotic drops. Ofloxacin is our favorite medicine. We don't use moxifloxacin for 24 hours. Povidone painting is essential, just like cataract. And it's a sterile OT. In West, the people walk in with shoes, suit, and all the tie, and they do LASIK and come out. And they are cleaner countries, but in our setup, it's better to always have as clean OT as we do it for a cataract. So eye shield for other eye, this is a very important thing. We do it for cataract as well as this. The patient is lying down there. You're going to put a drape there, and you ask the patient to keep the eye open, both the eyes open. Both the eyes have to be kept open so that you have toric markers absolutely on the spot. If you close one eye, this eye will rotate in clockwise or anti-clockwise direction. So if the patient has to keep both the eyes open, the drape should not touch the other eye. So we always put an sterile eye shield on the other eye. And proparacaine topical anesthesia drops, many times they put it half an hour before, 30 minutes before, whatever it is. I would recommend them to put only on the eye that's being operated. Other eye, we don't put proparacaine, because once you put proparacaine for the other eye and you ask the patient to keep the eye open, it's, it desiccates. It starts, becoming dry. And whenever the cornea becomes dry, it becomes thinner. And when you ablate it, it will be over ablating. So when always we start with the right eye. We put proparacaine only for the right eye, left eye, no anesthetic drops. After finishing right eye, then we'll start putting drops to the other eye. This is the most important step in LASIK as well as ASA. The patient, you have to inspect the patient when the patient is lying down. There should not be any head tilt, any rotation, chin elevation, chin depression position. You see from a side, go to the left side and see whether the chin and the forehead are on the same level. And then you center the eye with the joystick. You center it. Okay. Now imagine after you center, you're going to put a drape. After you put a drape, the patient turns head a little bit to another side. Then what are you going to do? You're going to adjust this, head position or the joystick. So the whole treatment is being done with the eye tilting or a chin elevated position. So after draping it, if there is a misalignment between the eye and the microscope, I would not touch the joystick. I adjust the patient's head. By that, we'll keep the patient's head under the drape in a proper position. So we have a suction lid speculum. This I devised about 2 decades ago because there's a lot of fluid comes on it. So if the suction lid speculum is applied on the eye and it attached to a suction apparatus, it is kept absolutely clean. Draping is very important. Irrigate copiously. And how do we remove the epithelium? Okay, if you're not doing transepithelial PRK, we remove the epithelium. The experts who have done a lot of PRKs, I've seen Dr. Kadambi is there, like a magic, he removes with a blunt, the old hockey stick. We know hockey stick type of a blade. He just does it, and in a few seconds, he removes the entire cornea. We are not as expert as him. We can use Amoil's brush, but then both of them will have a problem of the epithelial cells, the basal cells may remain on it, and you might not have removed everything. So what you're supposed to treat, when you treat it, it's a very fine treatment. What you're supposed to treat, you may not be treating on the stroma, you're starting treating on the epithelial level, there will be under treatment. So trans epithelial laser, I don't like this, though we have trans PRK in our machine. When you do a trans PRK, you're supposed to remove the epithelial cells, but epithelium thickness varies from place to place. Central epithelium may be thinner, mid-peripheral may be thicker, periphery may be thicker. And there may be, when in the case of astigmatism, the epithelial thickness may be different in different areas, steep axis and flat axis. So transepithelial treatment will not understand where the epithelium is thick or where it is thin. I don't personally like it, but it's a very popular treatment. It removes the epithelium. There is a way of doing it. Once you remove, when the epithelium, when the laser hits epithelium, it's a different color. When it finishes the epithelium and touches the Bowman's membrane, the color of the laser changes. You very carefully see. And as long as it's in the epithelium, it's one single color. Then at some point of time, there is a change from blue to green. When it changes, if you are very quickly stopping the laser, like in a 2-stage procedure, you go up to that, about 50% of spots are blue, 50% of spots are green. That's the place we're going to stop it and switch over to the refractive treatment. This is a very fine technique. I've done it a lot in the past. But again, when you look at the correctness of it, when I analyze my results, I never had beautiful results like when I get with the LASIK. I hope you understood the technique. When you're treating with even the single step trans PRK, you're going to treat it at the end point. Some of the islands of epithelium may be remaining in some areas. So when you start the refraction treatment, and those areas may be untreated or less treated when compared to the Bowman's membrane that's also exposed. In EpiLASIK, we have a fantastic machine called microepitome, where epithelium sheet is taken out. I'll show a video if the time permits. And it's either replaced or discarded. Today, nobody replaces it. Earlier, we used to replace the flaps back, thinking that the healing will be better or pain will be lesser, but none of them, or the regression will not happen. the scarring will be less. So that's why we used to put the sheet, epithelial sheet back. Beautifully, we used to spend a lot of time in removing epithelium, putting it back, but we observed that it is not happening. So today in epilepsy is out of fashion. We discard the flap in every case and allow a new flap to form from the peripheral, from the stem cells of the limbus. LASIK is the most popular treatment. I love this technique where I'll show you a video, 20% ethyl alcohol is used, and ethyl alcohol should be mixed with distilled water so that you get edema of the epithelium and it easily comes off. And generally we have calculated the timings in our hands with our source of alcohol, and we need about 40 seconds waiting so that the epithelium gets loosened, and very smooth Bowman surface because it doesn't act on the Bowman, and you have a beautiful starting point for your refractive correction. Epithelial flap today is not raised. Allegretto is the machine that we use. We have 500 hertz flying spot LASIK. It's a Gaussian profile. I'll not go into the details of it. And it ablates, least ablation is possible. To correct one diopter, it removes 13 microns. If the optical zone is 6 millimeter, we take 6 to 7 millimeters optical zone depending upon the pupil diameter. Wavefront optimized treatment is possible here. There's a long story, and it's very fast. One diopter is treated in 1.4 seconds. I already covered this. What are the complications of PRK? There can be an over or under correction. Most of the over and under correction is because of the time factor between the removal of epithelium and the starting of the laser. As long as epithelium is there, cornea is good. But once you remove the epithelium, every fraction of a second, not a second, every fraction of a second counts. Longer you see, you get the machine here, you focus it and all those things, longer you leave, the cornea desiccates very fast. I've seen cornea desiccating from 500 microns to 480 microns in 2-3 seconds. Then it goes to 460 microns in another 5 seconds. So it becomes thinner. After the treatment, when the patient goes back, it goes back to its original shape. That means you are over treating the cornea. So the time interval between the epithelial removal and starting of the laser should be absolutely instantaneous. You should be ready with, number one. Number two is the dryness. Imagine you're going to flood the cornea with fluid, and there is fluid on the top of the cornea when you start treating it. The fluid absorbs the laser and there will be under correction. So when you're starting treatment, if there is cornea, there's some amount of fluid that's why we had the aspirating these things. So no fluidization, neither be wet nor be absolutely dry. And regression can occur. That's again, a lot of factors are there in it. Central islands is not very common in the ASA. Descended ablation is a possibility, but then the modern lasers have got such good tracking system, such good centration system that's not an issue. Healing is a factor, and this is more often related to your preoperative assessment. There is no surface inflammation in the eye. These are almost not seen. Even corneal haze, it happens more if there is a preoperative inflammation, like there is a dry eye, the vitamin D is less, there are deficiency and tendency for keloid formation. These things can happen. Infections are extremely rare. In 20 to 23 years of our work, neither in a LASIK nor in surface ablation, we have seen any infection. And it's supposed to be 1:5, but it's nearly in our hands. This I have told. Dry eye Meibomian gland dropout is a must. You have to see this. You have to see a T-BUT, and you have to have the OSDI scores. And vitamin D levels are very important. And treat surface inflammation either with steroids, sometimes, or with antimetabolites. For months together you can treat. And autoimmune diseases, you'll have to be very, very careful about that. What has changed the scenario of surface ablation? In the beginning, I was very hesitant to use mitomycin. There is a long story of mitomycin usage, and you should always remember 2 milligram in 10 ml. Don't worry about the percentages. So it's very difficult to remember. It can be, if people have used 0.2%, that's 10 times stronger than this. and you can end up in problems. Remember 2 milligram in 10 ml. So that is should be the one which goes into the eye. 2 milligram of fresh mitomycin is formed with 10 milliliter of sterile solution, and you have to keep on the area. You don't have to keep the entire 9 millimeter treatment or 8 millimeter treatment. Scarring occurs only in the central 3-4 millimeter. That's the only area you want to treat with MMC, and the duration depends upon 30 seconds to 2 minutes. And there are studies say that even 15 seconds is good enough. But in my hands, in Indian eyes, I would need a minimum of 30 seconds in every case of ASA and maximum of 2 minutes when I'm retreating. And imagine we're going to retreat treatment, then you'll have to keep it for 2 minutes. So it depends upon how much is the thickness. Every 50 microns of ablation or every dioptric power of you can increase, you can play around maximum 2 minutes is what I use. Depending upon, we have used it for the last 2 decades. It's extremely safe on the cornea. So the action of mitomycin on the corneal stroma in the center is different from the action in the limbal area where we use it for glaucoma. There, it's a totally different scenario when compared to this. It may not be safe there, but it's extremely safe in the central cornea. So post-operatively, what do we do? Pain management is one of the main thing in ASA. And how do we manage? ASA can be as comfortable as LASIK. We have done a lot of work on it, a lot of tablets we have tried, and this is a thing that worked. And bandage contact lens has to be put on every patient at the end of treatment. Today, I've not tried ketorolac tromethamine, but there's a good way of doing it. Take a contact lens pouch, about 20 minutes at the beginning of the procedure, you put 0.2 ml of ketorolac into it and close it and keep it in a sterile area. 20 minutes, ketorolac gets absorbed into the BCL, and you put that BCL on the cornea, and that is, remember, 0.2 ml of ketorolac. So that is put into the contact lens, open it slightly and put it inside. And contact lens is removed on 4th post LASIK or 4th ASA day. And by then 4th day, every day you see that epithelial cells sheet coming and closing it. On 3rd day it closes, leave it there for 1 more day, and 4th day remove the contact lens. Some people keep the contact lens for as long as 1 week. Okay. You tell the patient about pain before itself. Pain, watering, swelling, decrease of vision. You tell them beforehand instead of it coming as a surprise. This is, is very important. One of the most important thing that I learned in avoiding pain is, see, when you remove the epithelium, there'll be tags of epithelium, loose epithelium that's in the periphery. Okay, you put a contact lens on it, when the contact lens will move by 0.5 millimeter, and those tags are put in stretch. The anesthesia effect is gone. Those tags get stretched, moved. This is my discovery. And if you remove all these tags, take a vexel and push the epithelium to the periphery, remove it as much as it goes. Anyway, it's going to reform from the periphery to center. So if you remove the tags, pain is almost not there. It's like you have a wound here and your shirt keeps touching the wound, you will have a pain there. Imagine you put a bandage on it and it's not going to touch anymore. The wound, it doesn't hurt you. So anything that touches the contact lens is a protection, but contact lens itself will be tugging on the flaps there. And if you remove all of them at the end of ablation or before ablation, you'll have beautiful. It's always better to remove it at the end of it so that you don't waste time between the epithelial removal and the beginning of laser. So cold packs is really good. Give them, keep cold, but don't put ice. Ice is scalding. So always ask them to put a bottle of water and pour it on a towel and then keep it on the eye. And refrigerate eye drops. I encourage them to put all eye drops in the refrigerator. So you put the drops which are cool and put it back on the eye. And paracetamol, ibuprofen, I give 2 tablets, and in case they have pain, they can take it. Ofloxacin, what I do is, ofloxacin, the patient would have started 1 day before. I would ask the patient to continue for 3 more days, and I'll put 0.5 ml of proparacaine, freshly opened proparacaine, into the bottle itself. So the patient will use this combination of ofloxacin and proparacaine for next 3 days. Proparacaine gives good anesthetic effect and the patients are going to be very comfortable. Very comfortable. But that is used only for 3 days, and after that you remove the contact lens and you throw away the drop. So that way it's a good way. And I never use prednisolone eye drops at all. Neither in LASIK nor in this thing, I don't use it. I use fluorometholone 3 times a day for 1 month from day one. And flubifen, why I don't use ketorolac is I'm very comfortable with flurbiprofen drops, which I use it, alternate with fluorometholone, flurbiprofen, totally 6 times a day. Both are for 1 month, but then flubifen, I continue once a day for 3 more months. So that's my routine for surface ablation. For LASIK, we stop at 3 to 4 weeks. Avoid sunlight on cornea for 6 months. This is the most important advice you will give to avoid the opacification. And 6 months, you should avoid patient going into sunlight. I remember I had a patient who was so excited, he started playing cricket outside. And though he was wearing a cap and glasses, he developed intense scarring. So that's a lesson for me to specifically instruct them to avoid UV light there. So I think I'll skip the next few slides because I've taken that enough time.
Can you show the videos, sir?
Yeah, I'll show. Is that visible, Dr. Mohan?
Yes, yes, sir.
Yes, sir.
This is the these are 20-year-old videos. These are recorded on tape. That's the Maloney's Maloney's keratoscope I had. So this is a lot of experimentation has happened. I've put alcohol there. I've aspirated alcohol using a sponge, and now that's remove the balanced salt solution now. So this is to carefully avoid it spilling onto the conjunctiva. Now these are very old videos. Technique has remained almost same, but this is I'm putting the flap back. This is how we started initially. I made a groove on the edge of the mark. This is slightly edematous epithelium there, and carefully you can see that I'm trying to retain. It looks very funny now. Retain the flap. Flap is larger in size ultimately when you have removed it. This comes on the superior side. This is an aspirating speculum. You can see the holes here, and you can see a hole there, and this is connected and continuously aspirating. So there is no water, it's dry. And this is what I was trying to tell you. Push it back, and it's uniform. It should be very quick. Now, when I'm doing it now, I don't keep the flap back. When I'm taking out the flap, I take out peripheral flap. I keep the central island there. Entire epithelium comes and sits on the central cornea, about 3, 4, 5 millimeter. And then I adjust the microscope. I'm about to start the laser. Then I remove the flap so that I can immediately start. That way, the overcorrection of the center is absolutely avoided. So now you can see it here after that treatment. I'm going to put the flap back, but as I said, it did not help me in any way. Now I'll remove it. That's an epitome. There is no blade there. There's a plastic disc. This I loved this technique. Initially, I soaked the cornea with balanced salt with distilled water so that the epithelial flap comes up easily. It goes back exactly like a flap, but the flap it takes out is only the epithelium, just the epithelium. The epithelium is supposed to be live. Unlike the alcohol flap, you finish it and then you can put the, I'll go a little fast, put the flap back and then you put a contact lens. Again, the epithelium is attached to one side, but it gets disarranged under the contact lens. It becomes a mess. When new epithelial cells come inside, this sheet of epithelium, it doesn't know what to do. It cannot go out because contact lens is sitting on it. So it doesn't serve purpose. All the investment we made for the epitome was a waste. That is a suction speculum. I just wanted to show you. one IV set is connected to that, and it's connected to the ordinary, very low powered suction apparatus, which is run throughout the treatment. So this is a patient with RK. I've done a lot of correction. These people have hypermetropia with a huge astigmatism. Initially, I used to do LASIK for these patients. It's a beautiful technique, but cornea is already weak. LASIK will further weaken it. One of the best indications after Mitomycin was invented, was introduced. I enjoy doing it on the surface. This is the cone, Maloney cone. We had only one, but we had dozens of. We copied Maloney's cone on a lathe, local lathe fellow. You give the Maloney cone, he'll create. They won't have rings, but this is wonderful to. It's very easy to hold it on the eye, stabilize the eye, and then you can aspirate it. Alcohol for full 40 seconds. Remove the alcohol. And now taking it out is a tough job. It's all adherent, and epithelium actually goes into the cuts that you have there. I can only release epithelium nicely in between the cuts. Even that is very tough. Removing epithelium in a case of post RK is not very easy, but you can struggle to take it out and make it as smooth as it's possible. And most of them are hyperopic ablations, as you know. And you can use a blunt. It's tough to remove epithelium in a case of RK. So try to make it as smooth as possible, and then start the ablation. This patient probably had +3 with +2 ablation, all in the periphery. That takes a little longer time. Myopia is very fast. Hyperopia, because it has to treat a larger area. It's and then Mitomycin. Mitomycin is very important. For full 2 minutes, you'll have to apply it. This is the way I apply Mitomycin. I soak a Vexel sponge with Mitomycin and smear it continuously in various areas. I will not go anywhere near the limbus, and then put a contact lens. Good results. Yeah, I would like to show the initially when I used to hate, Mitomycin being applied on the cornea, literally hate them. I had a series of cases, and that is how you see the haze related to PRK. It's usually centered to cornea, centered to the area of ablation. Maximally area is about 4 millimeter. That's way. What I'm trying to do, I did a lot of study as to should I correct the power, should I correct only thing. Then we decided to remove only the thick epithelium and ablate the So epithelium is removed now. And this has got, when you remove the epithelium, it's all bumps and valleys. There are elevated points, there are depressed points. When you treat with excimer laser, it treats both valleys and the bumps. So what do? You have to mask it, you have to make the surface smooth. Surface smooth is done by the Helon, 50% diluted Helon. And that what it does is that fills the valleys, and the ablation profile of the Helon is similar to the stroma. So then it fills the valleys and gives a smooth surface. So only the tops of hillocks are ablated when you do that. So now I'm putting a layer of the 0.5% sodium hyaluronate, which has got optical index similar to stroma, and fills the valleys and equates this thing. And you keep 20 microns, stop at every 20 microns of PTK treatment, and reapply masking agent. This is what I'm trying to do. I'm pushing it and apply only that area. It treats the hyaluronic acid in the valleys and the top of the. You keep doing it 20 microns at a time. It gives beautiful results, very good results. So till all the visible opacity is gone, you can do it. Go a little faster. PTK, you can adjust the amount of diameter of it, and at the end of it, you apply Mitomycin for 2 minutes, and that will be the end of your treatment. You can even do refraction. You can even do a refraction. You put a contact lens and you can scope it. If the power is too high, you can go back and correct the power, but always you can go back in a second sitting also. So it's almost clear now, and put a contact lens back. So this we have not seen it at all after we have started using mitomycin. So that's the journey we have had with surface ablation. We do a lot of surface. At some point of time, we shifted or completed to LASIK, but now we do a lot more surface ablations when compared to the LASIK. Thank you for giving me privilege. I'll be glad to interact with you in any way. I would like to learn more about smile technique and eagerly wait for Dr. Nair's lecture.
Thank you so much. I mean, this was to me, and also Dr. Mohan knows it very well, but for me, it was a history in motion. I mean, the way Dr. Ravindra took us from the first, and it's almost like a full circle. You called it PRK, and now 23 years later, you're calling it advanced surface ablation, but such a lot of modification and technique. And it was a pleasure. I think each slide had such a lot of information. I have a couple of questions while Dr. Manoj and Dr. Raj Shekhar could actually just look if there are any questions in the feed, while I just request Dr. Ravindra for a couple of questions, and I will welcome Swapna to also put in your thoughts. I mean, the level of knowledge that would be there with the two of them, I think it would be really amazing. For me, I think the real change has been how we treat the epithelium. I was, of course, started with the EPK and the plain PRK, which is about 12, 15 years back. But for me, the way we've treated epithelium has really changed. We earlier used to respect it. Then we decided we don't require it. Then we decided that, no, you need to be stricter with it, and then started putting mitomycin. Now, there is a lot of debate purely from the point of use of mito, and then with conditions, is there any cutoff for power? That was my first question, Dr. Ravindra. Second observation from my side is, I remember your slide saying that you even used higher powers, but traditionally we are taught that a -5 or a -6 would be a good cutoff. I want your opinions and Swapna's opinions, and anybody else, even Manoj or Raj Shekhar and Dr. Mohan, also has such fantastic knowledge on refractive. I would really welcome some views on this.
Yeah, thanks, Dr. Anand. About the mitomycin and respect to epithelium, every human tissue has to be respected. That's what Dr. Badrinath has taught me when I was a fellow there. His tissue handling is marvelous. He will actually feel bad when he says if he touches little more of tissue than what actually is necessary. I always remember him for this great advice, tissue respect. About mitomycin, I was very hesitant to use it, but burnt my fingers in the beginning. And I think there's one Dr. Majumdar, if I'm right, who is an authority in mitomycin usage. And he is a person, I attended one full course on mitomycin under him. And he is a person initially who said, safely use it on the cornea. He comes with tons of experience. And, being a corneal surgeon myself, I was very hesitant to use anything like mitomycin, which is a cytotoxic drug on the surface. About the limit of this thing, the LASIK, I got a lot more courage, I would say, when I visited Dr. Daljit Singh. Daljit Singh is a great proponent of surface ablation. He has never raised one single flap, never. Whatever may be the power, I've seen him operating on 16 diopter. When I was there, he has got about 20 Ks in a row. I mean, it just goes like his cataracts. 20 rays, he finishes in 45 minutes, all of them. So that's the speed of it, and nothing doing. And 16 diopters with some amount of astigmatism, we treated with PRK. Cornea was adequate. At the end of it, cornea might be 300 microns. I mean, he didn't look at the details. Somebody else would have worked on it. And then his difference, he does not even use mitomycin. Okay, his difference is only how much of steroids he's going to use. He used to put prednisolone eye drops very frequently into the eye for as long as 6 months' time. I've seen patients who have, and those patients are not followed up. They don't come back to you. They come from remote areas. I spent few days with this thing. I've seen patients who had intense glaucoma with so much of steroids that he used to use. And if you use a lot of steroids for a long time, scar will never form. So use either a lot of steroids or use mitomycin. Mitomycin in my own hands for the last 20 days, I never had to regret even in one case. Now we don't get scarring at all. So mitomycin is a thing. I don't think there is a limit for surface ablations. The only limit is the parameters of the cornea that you have, this curvature versus the thickness. But as far as the amount of ablation that's necessary, it's same. You do it on the surface, which is epithelium, the basement membrane, and Bowman's membrane. Bowman's membrane is nothing but a thickened stroma there. When the body creates another Bowman's membrane, it's thicker, it's opaque. So that you're going to nullify by using mitomycin. It's a tissue modulation, and you're not going to harm the eye on doing surface ablations at all. Surface ablation has got a lot of plus points when compared to the.
I have a couple of more queries, but I'll invite Swapna or Mohan. If
No,
you
I will. Can I ask a question? Anand.
Yes, sir. Please.
Sir, Dr. MSR, I think it's probably one of the best talks I ever heard on advanced surface ablation. I'm very glad that you have come the full cycle. And when I listened to your talk, I was reminded of none other than Dr. Babu Rajendran.
Yes.
Okay. He is a strong proponent of surface ablation. In fact, he was the first to start way back in even 95, 96. And he used to treat, I have seen personally, and he used to treat minus 20 diopter and without any mitomycin also. And even now the patients are coming to us without any problem. Absolutely fantastic. And you know, when Babu towards the last few years, because his laser machine conked, and he used to come and operate in Rajan Eye Care and he used to use our machine. Then Sujata will keep all the LASIK, everything ready. He says, I will do only PRK. And he will come and do only PRK. Even though Dr. Janakiraman, his associate, comes here and does only PRK for all his patients, irrespective of the power. There is no limit, and everybody, it's a versatile technique. Only thing is, nowadays we have got the newer modalities, as Ravindra said, really fantastic. And we are all bothered about the pain. The pain is not a very major issue, I feel. That another important thing is, I think we are all also bothered about the haze. Mitomycin is taking care of the haze, and we don't have to put these patients on long-term steroids also, for that matter. So at that time, there were the type 1 and type 2 healers. I don't know whether it still holds good, because these people, the type 2 or whatever it is, I'm not sure what exactly is the classification. But they used to say that the type 2 or type 1 or whatever it is, they have a more haze and that can be there for a longer time. So I want your inputs on that. But amazing talks, sir. You opened up a Pandora's box, actually.
Thanks, Mohan. I still remember Dr. Mohan's lecture. I think it was in Chennai. One of the AOS, huge gathering. He told his experiences. I tell my patients there will be intense pain, severe pain. You will be rolling in the bed. And, when they come, nobody calls him and troubles him. Next 2-3 days after that, it's all right, because it's a priming the mind of the patient. That time, all these pain avoiding techniques were not available. And he said at one point of time, one patient called me middle of the night, and I was amazed that in spite of telling so many times, why is she calling me? He called me up saying, Doctor Sir, you said so much of pain. I had no pain at all. That's why I wanted to find out, is there anything wrong? So this is exactly Babu told in that conference.
Absolutely, sir. Absolutely.
Swapna, would you like to?
Yeah, thank you, Anna. So regarding the time for which mitomycin is used, I follow protocol where you apply 10 seconds for every diopter of path, which is followed in a couple of institutions as well. So and we go up to 40, 50, 60. Overall around 1 minute should suffice for most patients. Because again, regarding the power and regarding the application of mitomycin, I also use a small disc of the wet cell sponge and keep it there so that the concentration is uniform all over the area, and each area gets the same time that the other does. So that's how I ensure that it's uniformly distributed. Of course, it stays away from the limbus as well. It doesn't overflow. So these are the ways by which I manage mitomycin. And regarding the power corrected, again, I think it's totally dependent on the curvature of the cornea and the pachymetry. So I wouldn't let any power distort the cornea from the prolate to the oblate form. So that is the first rule. And of course, the pachymetry as well.
And just a question to both Dr. Ravindra and Swapna. Is there a limit where you would say no, of thickness where you would say no laser surgery? Is there like a cutoff mentally that you keep, or when they say with epithelium all, if it's 450, 470, I would not touch the cornea. I would look at options beyond it. Do you have a cutoff?
470.
What, Dr. Ravindra?
No, my calculation is we do it two ways. At the end of the ablation, if it is LASIK, 300 microns. If it is surface ablation, 350 microns. That's a cutoff.
350.
350, that's what I take. Or 50% of the original corneal thickness. If the patient had very thick cornea, like 600. Okay, now 50% is 300 microns. There, it is not 250, it's 300 microns. If the average 540 is the thickness, 540, the half of it is 270. Okay, so minus epithelial thickness, it's above 250. That's good enough. That's a 50% thickness of the original cornea, or 350 of the bed.
Well, got it. I think that's
wonderful. Anand, we have a couple of questions also. We'll ask that also.
Sure.
One question is, I think he's an young ophthalmologist. He's asking, if a person is convinced for LASIK or wants LASIK, how will you counsel him into this ASA? This is a question. And another question, add-on question he's asking is ASA convenient for redoing or revising?
That's a very, very good question. I'll request Sapna to take the first question and Dr. Ravindra to take the second.
Well, if a person is convinced for LASIK and he knows the exact difference between LASIK and surface ablation, and he wants LASIK in spite of knowing all the other things that come with it, he's not an active sports person, then I think LASIK should be the way to go, because he must have obviously done enough research for that. Because technically, I don't see much of a difference if you are on the safer side with your eye after that. And of course, it's less inconveniencing to the patient immediately after the procedure. But if you have a choice as a surgeon, then I basically do trans-PRK. And when I do trans-PRK, I usually tell the patient that I am trying not to invade into your cornea too deep. So I have a whole lot of thickness to deal with. I can ensure you that, the amount of dryness you're going to get is much less, because I'm going to ablate only the anterior stroma. And another factor I point out is that you have no flap there, so there's nothing that's going to get displaced or rubbed off or subject to trauma. So if those points are able to convince the patient, and it's a touchless procedure, the laser does the entire thing, and I'm not going to scrape anything or use a blade or anything to lift off from your cornea. So if that can convince the patient, then good enough, the patient can go in for such a procedure.
The second question, Dr. Ravindra.
About
redoing or yes,
repeat procedures for LASIK, what we call touch up or repeat.
Or
we prefer to lift the flap. Yeah.
If it's a fresh case, like you've done LASIK and there is some error in the calculations, refraction or cylindrical axis, whatever technical errors, I will raise a flap if it is LASIK. But if it is ablation done on the surface, it's done on the surface. But if the patient comes much later, or that's you cross the limit of your ablation, LASIK ablation, you have already ablated to the edge of your possibility, then I would prefer a surface ablation for all these patients. Similarly, any cataract patient, any patient who has retinal problems, who has where you cannot apply the suction ring as much safely, I would like to do a surface ablation.
Okay, I think there's a good number of proponents for both, and I would really now, if there are any questions, Dr. Raj Shekhar.
One more question they've asked. I think he's a student. He's asking why no prednisolone. Will it not be good to use a short and strong and short course of steroid?
I think that's a good question.
Why no prednisolone?
That's a good question.
somehow, see, you're not
Personal preference or
no. It is logical. We don't have to treat the ciliary body or iris or something
Yeah.
like that in the laser. It's all on the surface. And surface, when you look at the effect of the drug on the surface, I don't think there is a huge difference between the prednisolone and fluoromethalone. Many patients, they don't come back for so many follow-ups. Their pressure can go up 30, 40. And the second is, post-LASIK, it's very difficult to assess the pressure. You can be misled. So
Correct.
with all these things considered, and fluoromethalone has given excellent results over decades, not years. I never use prednisolone in either LASIK or this thing. You have to, it acts on the surface very well. So that's the reason.
And
It's just a
Swapna,
logic.
any preference for steroids before we move on to your presentation while you set it
Yeah,
up?
so as far as LASIK is concerned, flap assisted LASIK, I'd use a fluoromethalone itself. But for all surface ablations, I make sure that initially I use prednisolone for a very limited amount of time, let's say 10 days or 12 days, and then convert the patient to fluoromethalone for a longer period of time. So that is the protocol I follow.
Perfect. Very nice. I think most would probably agree where you start off stronger and go with the lighter steroid.
Yeah.
Okay. Is there any question? Then I would request.
Done.
Anand.
From my end.
I think we are already near 9 o'clock. I think we should, we have 2 more topics to go.
Yeah.
Yeah. I think we should go on to the next topic and then we'll discuss it later.
Later, sure. I think such a lot to discuss, and I think for most refractive surgeons that most patients, most people would start with a surface ablation. So I think that's an important point of discussion. Sapna, we are waiting for your talk. Thank you so much.
Yes.
Thank you, Anand. So I'll just share my screen. Yeah, so I hope the screen is visible and I'm audible.
Yes.
Yeah. Okay. So now I've basically prepared this presentation for junior ophthalmologists and postgraduate students. So I'm sure that whoever is sitting on the panel may find it a bit, on the duller side, or maybe, So these are just some of the basics of femtosecond lasers that are used in refractive surgery. I'd like to thank Dr. Anand Parsati for having me here. And I'm very grateful to my seniors, Dr. Raj Shekhar, Dr. Mohan Rajan, Sujata Madam, and my peers who are over here as panelists and moderators. So as we all know, femtosecond is a very, very small fraction of a second. So just to sum it up, a femtosecond is to a second what a second is to 31.7 million years. So that is how small it is. So it is unimaginably small. Now, why do you use such a small pulse of laser? Is basically the amount of collateral damage with such a laser is very limited. So that is the whole concept behind a femtosecond compared to, let's say, a picosecond or a nanosecond and whatnot. Now, when you look at the light spectrum, we know that the visible spectrum is between 400 and 700 nanometers that you have over here. And whatever is less than that wavelength comes under ultraviolet, and whatever is more than that comes under infrared. So when we're talking about the excimer laser, we are dealing with the ultraviolet spectrum. So we should usually have excimer lasers in the range of 193 nanometers or 248 nanometers. And excimer, like Ravindra sir had clearly explained, is an excited dimer. On the other hand, the femtosecond laser comes slightly towards the infrared region. It's not hot, but it's between the visible and the infrared region. So you have wavelengths of 1050 nanometers over here. Now, basically, what's the difference between the femto and the excimer? So first of all, the generation of the laser. Excimer is generated when an inert gas reacts with a halogen, something like argon fluoride. And then you have a highly excited dimer over there. And this ultraviolet light, when it interacts with the tissues, it causes breaking of the bonds. And therefore, this breaking of the bonds is what causes tissue ablation in a very fine pattern. On the other hand, femtosecond uses a solid state laser. So there is mode coupling of this solid state laser, and this generates. Now what it means is that basically you have a crystal on which light is applied, and that light energy causes the release of a particular type of laser of a particular frequency and a particular pulse duration. And this is usually a picosecond laser which is generated, and this undergoes a process of compression into a femtosecond laser. So that is how femtosecond lasers are generated. So now we are talking of lasers on either side of the spectrum, and I'll be handling the one which is on the right side of the visible spectrum, the femtosecond lasers. Now, how do these lasers interact with tissue? We know that ablation is basically breaking of the bonds of tissue, which is done by the excimer laser, whereas femtosecond lasers disrupt tissue. So there is one more laser that can disrupt tissue, that is the Nd:YAG laser. But the difference is that the pulse duration in Nd:YAG is of the order of nanoseconds, whereas the pulse duration of femtosecond is of the order of femtoseconds, because of which the collateral damage is less. So you can see all that, all those bubbles and everything that come up when you do a YAG laser. Whereas when you do a femtosecond, it's simply cold and quiet out there. So that is what you want when you want to create an aberration-free interface. Now, thermal interaction of lasers like you use for coagulation is basically carbonization and vaporization, as you see in the first segment. Then you have photoablation where molecular bonds are broken, as with the excimer laser. And we are talking about photodisruption over here. So photodisruption involves ionization of the atoms to form a plasma. Now, this is the size of the femtosecond spot that we are talking about compared to the excimer spot. So you can see the huge difference between that. And this spot goes to the desired depth in the cornea, and the pulses are delivered in a preset pattern. So usually it's either a spiral pattern or a raster pattern, depending on which machine you're using. And it can cause cleavages in both the horizontal and vertical plane. And this is called laser-induced breakdown of tissues. So you have a focused femtosecond laser beam that focuses on a particular depth in the cornea. It causes ionization of the atoms over there, generates a plasma. Now this plasma expands suddenly and contracts. So there is a shock wave that's generated. And this shock wave causes cavities to form in between the layers of the tissue. And this cavitation bubble, this is the bubble that causes dehiscence of the tissue plane, and you get various planes that you're applying the laser in. So you have a cornea which is applanated so that the laser is uniformly spread and it follows a particular planar pattern. And then once the applanated cornea, the laser starts interacting, the gas bubble disrupts the cornea, and you have the cleavage plane form, the byproducts being carbon dioxide and water of this photo disruption process. So basically, we're talking about a process which is called photo disruption, compared to photoablation for the excimer and photocoagulation for the thermal lasers. So again, this is a summary of what I said right now. So you have the laser application, the formation of plasma, expansion of plasma under high pressure and contraction leading to cavitation bubbles, and these bubbles that disrupt the stroma, carbon dioxide and water being the end products of the process. So this is a cleavage plane that's formed. You can see that the planes can be formed either in the horizontal or the vertical patterns. That is how you can take an entire flap. You can have the planar area of the flap between the stroma and the flap, and the vertical side cuts, which allow access into the flap. So this photo disrupted area has to be gently cleaved using a blunt dissector, and then the flap is elevated and the excimer laser is applied. So now, how is a femtosecond laser advantageous over microkeratomes in creating a flap? The flap thickness is, of course, more predictable in the sense that we have seen that we use 90 micron or 110 micron blades for microkeratomes, and the flap that is generated with the first cut is usually slightly thicker than what you would expect it to be. So a 90 micron blade does not generate a 90 micron flap. Instead, it would create something to the tune of 106 or 107 microns. And in the second eye, it would be slightly less than this. So that is variable consistency of thickness of the flap. On the other hand, the femtosecond makes sure that the level at which the flap is generated is consistent depending on what you have programmed. So you can have 110 micron flaps, you can have 100 microns or 90 microns, whatever you have programmed. And you can go as thin as you want. So suppose you wanted a 70 micron flap, you could have created that too. But we usually don't do that for a lot of reasons that I'll be talking about before. And or you want an 80 micron, even an 82 micron flap. So you can do all those things with the femtosecond laser. And you know, the ability to play with the laser or customize it is very helpful in a lot of cases. Another thing is that the flap surface is very smooth. I'll show you some pictures which indicate that. So that the aberrations induced in such a flap compared to a method like cutting a flap using a keratome is much, much less, because the number of pulses that go over the area are huge. There are less tissue bridges in all the modern lasers. And so you have very smooth flaps. And of course, there's better preservation of corneal sensitivity. And to tell the patient you're using a very bladeless procedure. So what are the disadvantages of the blade that the flap is able to overcome? You can have buttonholing of a flap. That is, when you pass a blade through a cornea to cut a flap, you may get an area where the flap has a hole in it because that part of the cornea is not cut. And when you lift the flap, you have flap with a hole in it, and that ablation cannot be done. You have to let the flap heal, and maybe you can do a surface ablation later on. You can also have epithelial defects in the flap. This is because of traction of the microkeratome when you move it over the flap, if the cornea is a bit more dry. So you need to wet the cornea very well before moving the microkeratome blade over it. Of course, you can have incomplete or short flaps. That happens usually when you lose suction during the procedure, when there's a gross movement, or when there's something wrong with the suction apparatus of the keratome. And you can get an incomplete flap, which again may need to be repositioned back. Or if it is at the very edge, I mean, you have reached nearly the hinge, maybe you can use a small keratome to dissect the flap up to the hinge and carry on with the procedure. So these are all variabilities that you can get with the microkeratome, and all these are abolished when you use the femtosecond laser, because it's a pre-programmed laser that works exactly whatever is factored in. So here you have the femtosecond laser first creating a channel and then forming the flap. So this is a raster pattern. You can see that the side cut is dissected first, followed by the dissection of the flap, and you can see how smoothly the flap elevator moves in between the tissues. So the tissue bridges are very, very fine and virtually provide no resistance in all the modern lasers. Now, besides the femtosecond laser for excimer, you can also use it to create pockets where you can introduce things like the myoring over here. So this is something that is used to add tissue to the cornea and can be used in ectasias where you can place the myoring in the center, and that causes the steepening of the cornea, because of which, and flattening of the center cornea, from which refractive errors can be corrected. So such pockets can be created by the femtosecond laser. Another is used for ICRS. You can see how the ICRS ring is. So here I have created a whole ring type of pocket over here, and the ICRS segments are kept in either half. So everything is programmed by the laser. So you have an entire ring type of pattern plus a central cut through which the ICRS rings can be inserted. So whether you want to insert one ring or two, depends on the amount of power you want to correct or the amount of steepness of the cornea. And then you need to suture up the central cut through which the rings are inserted. So this also corrects myopia to a large extent in ectatic corneas, and the femtosecond is a very, very good tool, leading to a very good result. So you have virtually no extrusion of the rings, or no, it goes to the correct plane that you want to send it to. which is not possible with the manual, the keratome that you use for the rings otherwise. So now what are the disadvantages of the femtosecond laser? Of course, it's more expensive. There's an increased time of operation, especially in older technology. And there's more flap manipulation, especially when you're dissecting flap. I mean, instead of elevating the flap that you do after the microkeratome cut, you have a minor amount of dissection that you need to do. You may have an opaque bubble formation or bubbles in the anterior chamber. Now, coming to that, if you see over here, this is a laser that was going fine till there was a suction loss. And you can see how the femtosecond stops exactly at that point, and you have only half of a flap cut. For here, you will need to have this thing coming out and another ablation procedure. Maybe you have to cut along the same plane, or you may need to do a surface ablation in such cases. But you never go deeper because the bubbles prevent you from going deeper. Now, these are some anterior chamber bubbles that you can see over here. So these happen when bubbles dissect and come in through the trabecular meshwork into the anterior chamber. So instead of going out through the channel that you create initially with the femtosecond laser. You can also have an opaque bubble layer. That is when there is no channel here, as you can see, to let out the air that is formed, the gas bubbles that are formed in the interface, which leads them dissecting into the stroma. And such areas have larger tissue bridges and are harder to dissect. So these are some of the disadvantages of the femtosecond laser that you may not see with the microkeratome. Now, coming to one of the most modern techniques of use of femtosecond laser in refraction is for lenticule extraction. So basically, they are, the earliest one was the relax smile technique. So relax is refractive lenticule extraction. Earlier, they used to make a whole flap. So they used to create a lenticule on the cornea with an anterior surface, and so you have femtosecond laser that dissects both the anterior and posterior surfaces. And then you cut a flap open and pick out that lenticule and take it off. But then the smile, where there's a small incision, which is used to draw the lenticule out after the cutting of the anterior and posterior surfaces came up. Then, of course, what now is happening is the clear procedure, which is patented by Zimmer. Smile was by Carl Zeiss. In clear, you have a corneal lenticule extraction for advanced refractive correction. So here again, it's the same, only thing it's more tweakable. The centration of the procedure, the kind of power you can treat, and the depth to which you can go, everything can be tweaked, and it's a very versatile type of laser. So this is the lenticule plane that you create with such a procedure, both smile and clear. So you have, from the surface, you go in and you have an anterior plane and a posterior plane. You dissect each one of the planes and they meet at a particular point. And then you have a small incision through which these are extracted. Now, this is a clear procedure. So this is a programming happening where you put in the pachymetry, the optical zone you want to treat, the gap thickness, the depth to which you want to go, and the anterior and the posterior planes that you want to create. And once applanation happens on the cornea, you can see that the cornea is made planar and you get the spiral pattern over here for the anterior and posterior planes. The vacuum lasts stably during the entire procedure. And then you enter using the small incision that has been made on the side. You dissect the posterior plane, you dissect the anterior plane. And once you have reached all the way to the edges to make sure that the plane is, both the planes coincide at the edges, then you pick the lenticule out. So this procedure, the clear procedure, is also aided by the OCT visualization of the planes and the tunnels that you're creating, which was not there in the smile procedure. So using the intraoperative OCT, you can have better visualization of the planes you're trying to go through. You can have better visualization of where the tunnels enter the plane. You can verify what area has been applanated. And you can also see the stroma below the posterior lenticule, like over here. So you can know the exact depth of the stroma that is below the posterior lenticule. So here, this is the lenticule. And you can know the exact depth below the posterior lenticule, the exact depth at which the anterior part of the lenticule has been taken. And this is the guiding tunnel to the plane and guiding tunnel to the posterior plane. So all these are visualized very practically. And this, you can program it also. So if you feel that you need to leave a bit more depth, or you need to go a bit more deeper, or you need to position the tunnel in a different manner, rotate a bit more, you can do all that using the OCT over here. Now, this is what I was talking about. So all the modern lasers that extract the lenticule create very, very smooth surfaces. So we are not just chopping over there and then pulling out tissue. These are very, very smooth surfaces with very few tissue bridges, as you can see. So this is magnification, and this is higher magnification of same anterior and posterior surfaces of the lenticule. And you can see how smooth it is. So to summarize, femtosecond lasers are used in cornea, and they're used in cataract as well, and they have a wide spectrum of application. Basically in refractive surgery, they're used for pre-excimer flap lifting, for lenticular delineation, and they are also used to create channels, consistent channels for corneal segments. So these are the many ways in which they help in dealing with large amount of refractive errors. Thank you very much.
Wonderful, wonderful talk, Swapna.
Thank you, sir.
Very concise. I think it's exactly what we wanted in terms of introducing, because for us, femto seemed a very big step for people who've been doing microkeratome. Now, and now with the way the technology is, you don't really need to know microkeratome. Would you say that, Swapna, to really start femtosecond surgery?
Yeah, so that is a point, because I do see a lot of people who just start straight away on the femtosecond machine. I don't think that's a bad thing, but then only, I mean, when you know a microkeratome, the flap, its complications and everything, do you get to realize to some extent on how to handle a flap complication that may happen in a femtosecond laser as well. So I think that's a question of experience, basically. But yeah, it's not a very uphill task, I guess.
And I think that's a very important point you emphasize in terms of the planar type of flap. For people who are progressing from a keratome to a femtosecond, the way the flap handles, is it different? Because in my experience, it does look different in terms of a femto.
Yeah, so yeah, because as you know very well that it is a meniscus type of flap that you get with the microkeratome, and you have definite cuts and definite depths with the femtosecond laser. So some people have found, though I have not, that when you dissect the side cut, and suppose it is a 90-degree side cut, exactly perpendicular to the corneal surface, they found it harder to lift. But I've been using it since 2013, the femtosecond laser, and I have never ever found, but could be because my technicians have programmed it to be 70 degrees rather than 90 degrees. And relifting of the flap also, I don't think it is very hard how long you progress. But one thing I have noticed is that the scarring along the edges of the flap is much more pronounced in the femtosecond laser, which is one good point, because it prevents the epithelial ingrowth into the flap, which you see in many of the microkeratome LASIK flaps. But at the same time, there is a visible scarring, which is slightly more pronounced in the femtosecond laser under the microscope, under the slit lamp microscope, compared to the microkeratome.
I would just put you in a spot, Sapna. Can you tell me maybe one condition where you say, I would only do a microkeratome, and in one condition where I would say, no, this femto is the only way to go, just as a point of discussion? Do you feel microkeratome still has some place where you would still want to do it? Does it have a place?
If there is a corneal opacity, perhaps, where you may not have the femtosecond laser passing through to reach a deeper plane. But then most probably in such a case, I'll do only a surface ablation rather than, use a flap. But yeah, definitely if there is a corneal opacity, then definitely it would be more wiser to use a blade that will cut at any plane you want it to, irrespective of the opacity. And then when would I do a femtosecond alone? If I want a very thin flap, and a flap I'm sure is of, that particular thickness alone. I don't want to take, hypothesis as to, what the thickness of the flap is. So suppose I want a very small flap, like, 90, exactly 90 microns for whatever reason, then maybe I'll use a.
So the accuracy of the femto is something that would work for you. Any questions?
Yeah, a
from...
couple of questions here, Anand. One is like, how long will you predict before microkeratome becomes obsolete? Swapna?
I think it's obsolete in many centers right now itself.
So as on date, it is obsolete.
Okay.
Oh,
Yeah,
so
in a couple of,
preferential.
and even, actually Moria, which used to be one of the producers of the microkeratome that a lot of people use, they also phasing it out sort of, I mean, they're not very ready to sell it nowadays. So I think a lot of people, and especially after Smile patent has gone away from Carl Zeiss and everyone is producing, the laser, and then you have femto. So a lot of people, and trans BRK, which is a type of surface ablation, like advanced surface ablation that Ravindra sir does. So I think microkeratome is getting a bit
Will
better.
slowly go. And the next question is, corneal hypoesthesia should be more with cavitation and cutting than with a clean machine cut. That is a question.
Yeah.
In terms of anesthesia, I think,
yeah, whichever way you cut, there will be corneal hypothesis. No
But the person who asks thinks that if you cavitate and cut, probably it will be, the nerve fibers will be damaged more. Yeah.
It is not just the cut, because you're ablating the cornea. There are nerves there too. So it is not just the cut which is causing the hypothesis.
Yeah.
And Dr. Ravindra,
Great.
anything?
Great. It's wonderful.
Sujata has come into the pair. Ask her. Raj Shekhar.
Yeah, sir. Yes, sir.
Sujata is back. Yeah.
Oh, great. Dr. Sujata, lovely to have you back. Just we were just having a discussion, femto versus microkeratome. Your opinions?
Yeah, I was hearing that. I think I will agree with both of you that microkeratome is almost gone. I would, my first choice and the only choice would be a femto. But if the patient cannot afford, that would be the only reason why I would do a microkeratome. In fact, I would rather do a PRK than a microkeratome because the safety factors so much with a femto. I really started disliking doing a microkeratome cut.
Yeah, I think all surgeons still, the microkeratome comes off and the flap is still there, your heart is in the mouth. However experienced you may be, I think till you can lift the flap and ablate, that part of anxiety tends to be there. Anything you'd like to add?
Hold your breath. Wait till the cut is.
Dr. Ravindra, anything you'd like to add before we go on to the next part?
No, I think she has covered everything. And one of the good point about femto flap is the trough. I mean, putting the flap back to its original place is much easier with femto than with microkeratome. But in our center, we use all of them, ASA, femto, as well as microkeratome. Even now we use microkeratome. We have Amadeus, which is, in my opinion, one of the best microkeratome that's available. Today is the last class. That's it. I think it's an excellent lecture, Dr. Nair. Thank you.
Thanks.
Great.
Dr. Nair.
So, Dr. Anand, all yours.
Okay. One question from me.
No, but
advanced course will be taken by February. Yes, I will be taking that.
hello.
Dr. Nair, I have a question.
Yeah. Yes.
You said the smile technique is no more held by one company. Anybody can use it. Can you suggest if somebody is looking for buying a smile machine, what are the options he has today? All of you can tell.
Zymer is there.
Zymer is there, sir, and then there is
J&J is coming out
also, which has actually launched its smile recently. And Zymer, the good thing, sir, is that it has both cataract and cornea. It has the entire gamut. It is nearly only as expensive as Zeiss was selling its smile for. But you can have the entire.
Smart doctor has got it.
Yeah, he's got it. He's the second person.
And J&J is also coming out with a smile. It's called Silk.
Silk?
Yeah, small incision, lenticular keratome will use this.
Okay.
So it's going to be called, it's called Elita. And they are going to come out, it's probably be out by end of this year.
Okay. Dr. Mohan, how do you compare these three machines? The one which is existing technology for a long time, Zeiss one, versus the other two?
Because I think Zeiss has branded, they were the first movers as far as smile is concerned. So now patients are coming and asking for Smile.
Smile. Yes.
So it's a brand recall, no, which is very, very important in especially technologies like this. And brand recall, I think Smile has gone way ahead. And even other companies, Zymer and all, I think they have named it as Clear Smile. Sujata probably will give more inputs on this.
Okay.
Sujata, where is she? Yeah, but they're calling it Clear Smile.
Clear Smile.
Yeah, and
Yes.
the difference is that they have a wider range of power correction. Unlike what Zeiss had, they have an intraoperative OCT, and and the positioning can be done from any side. Suppose you are a left-handed surgeon, you can go to the left and create your incision to enter the plane. You have a guiding tunnel both for the anterior and the posterior plane. So there are minor differences. So
What about the customization? You can
yes,
you
yes,
have
definitely,
huge
sir,
options.
definitely.
Is there in Smile?
Yeah, I think Smile would a lot of people say even femto in terms of Excimer may not be the future, but from what my impression is, you would require both in your OT. If you cannot get rid of this Excimer, you would still require the Smile if you want to be ahead. So in terms of femto, anything you'd like to add, Dr. Sujata, before we go on to the last?
What about the computing technology, Sujata?
Unmute yourself.
Please unmute.
Yeah. What was the question? What was
Smile versus as Excimer versus a pure femto procedure. Excimer, would it be something that you would think would still exist, let's say 10 years from now?
Absolutely. I still feel that Excimer technology has its role, though of course Smile is slowly replacing a majority of the patients with who need, because now they've come up with the astigmatism correction, hyperopia, so all those things. But still, I think the finesse that we get in Excimer, I'm not very sure whether the Smile would be able to give us. Yeah, but it's still possible. I think till that time that we say that, it's equivalent to Excimer, the Excimer will still stay. What is your opinion on that?
My opinion is I would probably think both would be required at any one moment of time. I don't think there's anything going extinct, because Excimer, just the ease of doing it is always going to be attractive.
Yeah.
Great. So we'll start with Dr. Anand. Anand, your.
Okay. All right. So I think all of us are reasonably hypoglycemic as well. Yeah. Thank you so much. And I'm just amazed at the amount of information and knowledge that the panelists have, and I'm extremely grateful for actually having the opportunity to host all of them. I just wanted to put this definition at the start of the procedure, and the picture is extremely important as a postgraduate, because when you look at phakic IOL, the definition is basically the implantation procedure involves a procedure similar to cataract surgery, and the main difference is, unlike cataract surgery, this does not involve removal of the eye's crystalline lens. And unlike LASIK or PRK, this does not involve removal of corneal tissue. So this basically is what the definition is. And I did want to touch upon two important parts about preoperative evaluation. And some of us do have optometrists, some of us don't. But I think a refraction in terms of what we get as the final outcome is a lot dependent on the optometrist. That is, of course, an important part about the history in terms of contact lens wear, which was touched about earlier, family history in terms of stability of any previous procedure, and also something about night vision, how most myopes tend to have a bit of glare, and that needs to be inquired about. There are some systemic contraindications for any refractive surgery, all the three that we are discussing today, in terms of autoimmune, collagen, or immunodeficiency. We do prefer to avoid pregnancy and nursing, because nursing mothers, because that can cause a change in the refractive error due to changes in hydration, and of course, uncontrolled diabetes. Now, when you discontinue the contact lens use, the visual acuity becomes important. You have to look at both the uncorrected and the best corrected vision with the previous glasses. And previous glasses is a very important factor to decide whether there's a significant change and whether the refraction is stable. Pinhole acuity, because that's the best possible vision that is possible for that patient, and near acuity if the patient is beyond 35 and they have a lot of computer work. Remember, it's important to make sure that make the patient aware whether patient has 6x6 vision or 100% vision even before we start surgery, because a lot of the high myopes and high astigmats do not have a perfect vision. They would be 6/9 parts, maybe 6/12, and that would be the limit of the vision. Now, usually what we say is well begun is half done. I believe strongly that retinoscopy and combined with reconfirmation with autorefraction is important. Duochrome test also important in all refractive procedures, including the LASIK, ASA, or even femtosecond, because you need to have duochrome balancing. You need to have the perfect axis, because the machine will only do what you enter. If that is not perfect, you would get imperfect outcomes. You do get occasional patients, especially high myopes, who do not have binocular perfect fusion. This is important because high myopes tend to have a bit of exotropia. You can occasionally see that if there is mild amblyopia. A lot of times, high myopes tend to have one eye, maybe a 6/12 with a -10. The other eye could be maybe a -8 with 6x6, but there'll always be a dominance, and binocular balance and checking the dominance becomes important. A very simple way of checking dominance is to just extend your hand with the thumb in front of your face, close the left and right eyes, and see in which in front of which eye is the thumb, and that is your dominant eye, and that is important, especially if you're planning for a mild monovision. Now, the final refraction is basically a combination of the old prescription glasses, the autorefractometer, the first subjective refraction, and also look at astigmatism. You do look at vertex distance, because some patients may actually tend to push the glasses down, some may actually keep it close to the eyes, and the way they handle the glasses is an important factor. This is, of course, routine for any surgery when you look at lids, conjunctiva, cornea, pupil, and of course, any lens opacity if you are considering a phakic IOL, because that it should not be that the lens opacity was not noticed earlier, or patient is has early cataract and you put in a phakic lens, you end up looking at surgery once again. Fundus evaluation, extremely important in high myopes. This helps to rule out peripheral retinal changes. You can also look at to see if there is any lattice with or without holes, and those need to be treated. A common question is asked for any refractive procedure: what is the gap? Usually we do recommend about 2 weeks between the laser and the procedure, but what I have also noticed is as soon as there is a bit of scarring which starts along the edge of the barrage, you can actually go ahead, but I would welcome some inputs as well. Now, TBUT is important, that is tear breakup time. Now, a lot of it, you have non-invasive tear breakup time, but you can actually just do it with the fluorescein, Schirmer's test, and also check for syringing if there is excessive watering. We always focus on dry eyes in refractive surgery, but I realize that even excessive watering can be something that needs to be ruled out. They may have an old or a constriction of the nasolacrimal duct, which could be troublesome. I'm not sure how many of us remember this, but this machine is still there. It's a keratometer, and it's important, especially if you want to manually check it. Though the accuracy of the present machines, this is probably not that commonly used anywhere. What is more commonly used is machines like the OpScan or the Pentacam. Just for the benefit of the postgraduates, it gives you a quad map where you're looking at the anterior float, the posterior float to see if there are any changes in the posterior cornea. You also look at the topography. You can find that this is against the rule topography in this patient, and you look at thickness. These are what we call a quad map. This is important, and in the central part tells you the same part, the astigmatism, the amount of powers. It also gives you the white to white, which is important for measuring for phakic IOLs. It also gives you the antechamber depth, and as I'll touch upon it, this is an important factor when you're looking at whether you want to go for a phakic IOL. An important factor is, and when you're looking at antechamber depth, you need to know your machine, which does it give you the depth of the antechamber from the endothelium or from the epithelium. Remember that most optical biometers do measure it from the epithelium. The OpScan measure it from the endothelium. So if you're measuring from the epithelium, you need to deduct the corneal thickness before you plan for anything. There are now, of course, different Scheimpflug images as well, imaging which gives you, and like in this patient, a mild keratoconus, irregular astigmatism, also in a similar quad map where you have front, back, the corneal thickness, and a front topography. And this basically helps you decide. Now, this patient, just for an example, has what we call keratoconus, whereas there is a superior inferior asymmetry. There is, of course, a separate lecture you can have on topography, and that's something as postgraduates used to be quite intimidating to remember, and that's something probably the ARC could look at. There are, if you're looking at surface ablation, there is a special machine called the topolizer, which you can actually image only the front part and then do the planning if you're looking at PRK or customized ablations as well. Aberrometry in patients who have very high abrasions, ICL may not be a very good factor. Basically, if you have a very significant amount of abrasions in the eye, it's a good idea to have a combination where you can reduce the abrasions to procedures like customized ablation, and then do the balanced refractive error, which is the sphere and the astigmatism using a ICL. Almost all patients of refractive surgery need to undergo an A scan, a biometry. Remember, ICL patients, now we recommend at least something between 2.8 to 3 millimeters antechamber depth. But what it really gives us is the range. And implantable contact lens or a phakic IOL can give us correction from -3 up to -23, and even sphere from hyperopia from +3 to almost about +12. You can measure what is HVID stands for horizontal visible iris diameter. It's a surrogate for white to white, and also important factor while deciding the size of the phakic IOL. Now, phakic IOL is basically either made from polymer or a hydrophilic acrylic. The polymer material, which was the first that came out from a company called Star, is a polymer of multiple hema polymers, and it is made with collagen and water. Most of these, not only the ICL, has very good biocompatibility with the eyes, because we have now patients who are 15, 18 years post-surgery. But remember that we didn't always start with posterior chamber IOLs. We started with anterior chamber iris. These were iris fixated, and I'm sure Dr. Ravindra Mohan also know, where you had artisan lenses, you had toric artisan, Verisize, Artiflex, and you had angle supported, a whole host of them. Even up to almost about 6-7 years back, where we had some antechamber acrylic lenses. Now, most of them are withdrawn or very, very rarely used. Almost all of us have shifted to what we call posterior chamber, which is, since I'm a nationalist, I feel that we should give a lot of respect to the Indian companies, IOCare, Biotech, Apasami, and of course, the Vizian, who actually initiated the whole ICL revolution. A characteristic of an ideal phakic IOL is, of course, the customization. You can go from any power, even as low as -1 now, to almost as high as -20. The other important factor is biocompatibility, because just like an IOL, these lenses are going to be in the eye for a very long time. So long-term follow-up extremely important. Optical characteristics is important, because you are putting an additional layer between the phakic lens and the cornea, and the light transmission needs to be almost about 90+%. And optical clarity is important, because the refractive index should not change the optics of the eye. Of course, any surgery, you need to have ease of insertion, flexibility, and ease of removal if there is an exchange required. And flexibility is extremely important in some of these patients. Now, I've just put this, it's a slightly busy slide, just to the highlighted red areas tell you that we actually started with PMMA. The IOLs that we had 25, 30 years back, at least some of us still use it, have been the starting point. And now we have shifted to polymer, even silicon was at one time used. Sorry. As I mentioned, the customization is important, and that's a very big plus factor. What is also important is the size of the optic. Now, we know IOLs have an optic between 6 to 6.5, most of the hydrophilic acrylic. But when you're looking at myopic ICLs or myopic phakic IOLs, because of the size, the thickness, most of them are restricted. Higher the myopia number, the smaller the optic diameter. So pupil measurement becomes an important factor. The other is the size of the white to white, because that's the factor of the size of the lens. Remember that there is only limited space between white to white, and the phakic IOL has to fit it. It has to stay away from the cornea. It also has to stay away from the lens. So the phakic measurement of the white to white measurement becomes a very, very important factor. Now, there is some studies which looked at what are the different materials that are actually biocompatible. But just to show that the aqueous has certain materials which actually cover up, we explanted a ICL almost about 8 years post because of vaulting issues. And we could find that there have been very few cellular deposits. So a lot of them are actually biocompatible, but it's not that they do not have any cellular deposition. Now, there's an important factor called the lens design, and most of them come with a plate haptic design, which is similar to some of the lenses that we use. And it has a central convex or basically a central convex zone and a concave optical zone. So this is where the power of the phakic IOL is. This basically vaults beyond the lens. Now, that is basically to minimize the contact with the central anterior capsule. You have this central vault. So the periphery of the lens is slightly more anterior. The central is slightly concave, or to give you the power correction. As I said, you can have 4.9 to about 5.8, and the diameter can vary from 12 to almost about 13.7. So you can put in fairly large lenses as well. Vision is where we've had good experience and also have longer follow-ups, almost about 15 years plus. And these are foldable. Most of the time, the incision needs to be about 3 to 3.5. So this is slightly larger than a phaco incision of a 2.2 or a 2.8. Comfortably, most of these phakic lenses go between 3 to 3.5. And it is then completely positioned inside the phakic, the posterior chamber. This is a list, and it's probably not really applicable in this. What is important in almost all of these phakic lenses have important landmarks for avoiding flipping of the lens, because if you flip the lens inside the anterior chamber, the convex part will be touching directly on the lens, and then you probably will end up with significant problems with IOP and of course cataract. Now, these are the marks which are you need to look very carefully when you're inserting it, and I'll mention that in the video as well, where you have to have the leading part of the optic to be on the right side. This hole which is there on the needs to be on the right, and the trailing needs to be on the left. Some of the toric lenses do not have these holes, but most of the present generation toric ICLs or phakic lenses have these holes, which allow aqueous egress and basically helps in maintaining the health of the lens as well. 2.8 was what we started with. It's also important to do the endothelial cell density. You need to make sure there's no associated lenticular abnormalities like subluxation or zonal laxity, because these lenses are basically sitting between the iris and resting on the lens zonules. There needs to be no corneal pathology, and of course a healthy peripheral retina. You need to have caution in diabetics, patient on long-term systemic steroids, because that can progress to cataract, and thyroid dysfunction, because you need a very stable ocular surface. This is probably the most important step in ICL surgery. We've gone through multiple generations of the OpScan. Manual still works, and when we didn't have access to these machines, manual is actually reasonably okay. You can do an anterior segment OCT. The present generation topography and tomography machines give you very good results. And earlier we used to actually do UBM in all these patients, but I think that is more or less given up. This is important because the posterior chamber IOLs can rotate and decenter if the sizing is not correct. And if it's too large, it will push the iris forward due to excessive vault and can lead to increased pigment dispersion and possible glaucoma. An ICL that is too small, or a phakic IOL too small, can have a risk of touch with the anterior lens capsule and increase the chance of cataract formation. Now, there was a lot of good agreement from studies saying that UBM and OpScan 2 is probably the safest, but most patients are now done with a manual measurement or with even the pentacam measurements. Remember that pentacam optical biometry should be mandatory now in almost any preoperative evaluation, because it increases the predictability of the postoperative vault and hence enhances the safety of the procedure. This is just a short video. This is just a short video to show how it is done. Now, this is a toric ICL, and we are marking just like a toric IOL to place the ICL. This is the axis of placement. We make a temporal incision. In this, we are taking a 2.8 incision. We put in a bit of viscoelastic to make sure the AC is formed. And just like an IOL injector, you have an ICL injector, but here you inject it very, very, very slowly. Make sure there is no flipping. The marks are kept. And if you look very carefully, it has the toric IOL marks which are near the optic haptic junction. You then push the haptics under the iris very gently. So you go distal first, push. There are, remember, 4 haptics of the IOL, the plate haptics. You push both of them under the iris distally and then proximally. and then position the toric part as per the axis marking, just like an IOL. A lot of the present phakic lenses do not require these placements. This is with the star ICL, the present Apasami or even biotech, you just need to mark the 0 and 180, and that really also gives very good results. Sorry. Just a note that at present, I think for postgraduates, it's important that you look at meta-analysis. And now, as far as I know, there's one good meta-analysis under the Cochrane review, which showed that for very high myopes, the phakic IOL is actually a good option. And if you have scotopic pupil sizes, contrast sensitivity is actually quite good. I will skip this. This is how a perfect ICL looks, where you have the lens, you have the phakic IOL in place. The depth is between the distance between the lens and the phakic IOL is equal to thickness of the cornea, which is about 500 to 800 microns. So that's what you're looking for, a very quiet eye post-surgery. This is just to show one patient now. He's almost 8 years post-op in a graft patient. We actually did a toric ICL post-DALC, the deep anterior lamellar capacity, and patient still maintains a good vision. So it's possible to do it sometimes in slightly more complicated cases as well. This is broadly how I do it, where you have to look at astigmatism and the amount of myopia. For low myopes, I do prefer the surface treatments now. For advanced higher myopes, if the anterior chamber depth is adequate, a phakic lens actually works quite well. Just also to know that there is no perfect solution. For each patient, you need to look at corneal thickness, the anterior chamber depth. You need to take a decision versus intraocular versus corneal procedures. An important factor now these days is patient occupation before you take a decision. In conclusion, for me, a correction of patient with thin corneas for moderate to high myopia, phakic IOL is a good option. For low to moderate with suspect topography, it may be a good option in patients that may not be eligible for a laser vision correction. Thank you so much, and it was lovely having all of you here. Thank you, Manoj and Raj Shekhar and Dr. Mohan, for giving me an opportunity to moderate this.
Nice, Anand. Very thorough and very beautiful.
I think it was a true master, which is speaking. And Anand Parsadi, I think, fitted the role so very well. A true master class it was. And the entire gamut of refractive surgery, and starting from the advanced surface ablation and the femtosecond, and of course the phakic IOL, everything has been covered. Fantastic, Anand. Thanks a lot.
Great. And the master has couple of questions. A scan later. That is a question. Probably the person is referring to, will we be able to do an cataract related IOL measurement later conveniently, or do we take the pre-operative measurements, pre-ICL measurements?
That's a good question. I think we have most of now a lot of those patients occasionally who had issues with Walt or had high myopia have developed, and we do have operated, and I got expertise from Swapna as well on this. But the optical biometry does not vary. The ultrasound biometry does not vary. So you can repeat the ultrasound and go ahead with whatever IOL measurements. The lens actually doesn't change much. The thickness of the lens doesn't alter the IOL power that much.
Swapna will want to add something?
No, exactly what Anand said.
Yeah.
It doesn't change.
Yeah.
The astigmatism may, but this thing does.
Yeah. And another question. The corneal incision, do you place it specifically somewhere? The corneal incision in an ICL. Where do you better place the incision?
I think the accepted modality, and since most of the ICLs are placed in the 0-180 now, it will be temporal. It will almost always be.
Yeah. So that's very much like in a phaco, in a regular frame. Okay, that is it, Anand. That is it. Very happy to have you and Dr. Ravindra and Dr. Swapna. Now, President, sir, your remarks, and we'll go for vote of thanks.
Sir, can I ask 2 questions to?
Yeah, please, sir.
Any questions from the audience?
Yeah.
The number 1 is the most crucial in ICL is the white to white diameter, and it's in some range of patients where it's not circular. There is an element of overlapping of cornea onto the sclera. It extends to the scleral side. it's very difficult to find out the white to white in horizontal meridian. So can you give us some tips as to how to, what part to take to what part to what part? Number two is your corneal incisions are like phaco incisions. They're almost 0.5 millimeter inside onto the cornea. I would rather take it from the limbus. I'll see that the vessel's palisade is not touched. Just in front of it, I'll take it. It's a short tunnel. In ICL, you don't have to have a long tunnel. So what's your comments on the actual position of the tunnel onto the corneal side versus the anterior limbal position? Third is, what are the complications you had with ICL with your long experience? So at any point of time, you had to change the lens due to wall alterations or any other issues that you had. You had any issues with the intraocular pressure post-operatively? How do you manage them? From practical point of view, if you can cover.
I think there are a lot of questions you've asked, and I'll try and take it one by one. One is in terms of the measurement of white to white, and that's a very valid query because all limbus are not the same. So what we have had, and finally what we do now is basically take at least 2 measurements in the either with a caliper, which I feel is what you see is what you get kind of thing. And the second is taking one automated measurement for which could be an optical biometer. The present set of anterior segment OCTs are really excellent. I mean, I've had opportunity to look at the anterior, and you can actually measure the sulcus to sulcus across all sectors. So that would be a good starting point. In case where there is an overlap, I do feel that the sulcus sizes are not usually uniform all across. In fact, I remember one study from a Korean group which said the horizontal white to white is in their eyes was actually longer than the horizontal. You know, the vertical was longer than the horizontal. So in a couple of patients whom we felt the vault was actually on the shallower side, we went back and twisted it supranasal and supratemporal. So that is one way of looking at it. I feel the vision where you see the overlap, I would prefer to err on the sides of a slightly higher wall than a lower wall. Now, the second question is in terms of complications or IOP rise. In now almost about 16 plus years, we had one patient in which the PI was not patent, and patient developed a high IOP. And now we more or less shifted out of IOP rises because of the holes. Of course, a very good point is to make sure you spend a bit of time washing off the visco and making sure there's no visco VI. I leave all patients dilated post-op, and I do remove the patch in 2 hours just to check sure if they are comfortable. The third part is in terms of cataract, and in fact, just today, the last patient I saw was a phakic IOL done about 12 years back. And about a couple of weeks back, we had a discussion with Sapna on post phakic IOL cataract calculations. Now, we are eventually going to see them because it's been about 12 years of using these lenses, and our sizing was not that accurate. So in the next 10 years, a lot of patients with a phakic IOL may end up with cataract, but myopes anyway progress, especially high myopes progress faster to cataract. Now, there is no change in the calculation that we really know. Dr. Sri Ganesh gave a very good advice on how to do the calculation using the Barrett's, and now I err a bit on myopia when I'm doing post-phakic IOL cataracts. I try and maintain the ICL in place. So even during the surgery, I try and maintain the ICL in place rather than removing both the lenses. It does require a bit of calculation to be done, and we could probably have, if you're really interested, I can share that. But if there is a verisize, which we did about 4 months back, I usually remove all verisize. If there are anti-chamber lenses, I do not maintain any of these lenses because they have endothelial cell loss for sure. The last part was the placement of the incision. I would agree to a certain extent, especially in keratoconus patients, to go slightly more limbal or even scleral. But for simple myopes, I find a short tunnel is a good suggestion. But I guess out of habit, we tend to make slightly longer tunnels because you're not really manipulating the tunnel. So even a shorter 1 millimeter tunnel will work equally well. But placement, will it make a difference on the astigmatism? Because some of them tend to be slightly larger tunnels. The acrylic lenses, especially the Indian-made hydrophilic lenses, require a slightly larger tunnel. They are not that easy to manipulate, and they are definitely a lot more difficult to explant. because they do not come out through the incision that you put it through. So in a terms of exchange, I've done one for a fake ICL, which we did about 12 years for a slightly higher wall, but even though the pressures were okay, I've done only one exchange. So it is not that difficult to do in a star ICL, but as far as I know, my experience with hydrophilic acrylics, most patients who had to, most doctors who had to exchange it, it's not that easy.
So what are your comments on long-term stay in the eye of columnar lenses versus hydrophilic lenses, the acrylic hydro lenses?
Acrylic has been around for 5 years. I'm sure Dr. Mohan and Dr. Sujata would be able to give slightly more inputs on hydrophilic acrylic long-term follow-ups. My longest I've had with acrylics about 2 years, which is actually quite stable.
More than 5-6 years we've been using.
Yes.
Using the IPCL, RIL. Now you are using the
Anand, only recently we have been using more of them. I was sticking to ICL for quite a long time, and only for the past 2-3 years maybe we're using Indian lenses. See, it's become very competitive. Patients cannot afford, and everywhere else, people are doing at a lower rate. We just cannot stick to the ICL. You have to compromise, and having used them, and I have no. I'm quite happy with them. I've not had any problems with any of them. Initially, some problem with the marking was there in IPCL, and so a couple of my lenses became ulta. So I had to change it inside itself. I realized it even as I was implanting it, because the marks were exactly opposite to ICL. It comes that they had not informed, and so that was in the very initial stages. Then after that, I realized it. Fortunately, I realized it on the table and I did it. But other than that, I have no issues at all. I've used all the lenses. I've used Apasami, Biotech, IPCL. They're all good.
Dr. Swapna, Manoj, anything you'd like to add?
Anand, I wonder. Anand.
Clear cornea to clear cornea is what I'll use for Ravindra sir's white to white measurement. When you have a limbus which is slightly spread out.
Exactly.
That is what the company refers to also. Clear cornea to clear cornea when you're using a digital marker. All other markers, like even when you take the sulcus, that is decided by a human as to where you're going to mark the, the point where you call the sulcus with the line passing through the angle to angle area. So sulcus measurements, and I don't think sulcus measurements can be accurately incorporated into the star ICL's calculation program also, because they basically recommend either the OpScan or the white to white measurements taken by the digital caliper. I still stick to the digital caliper because I don't use an OpScan, I use a Sirius. Then regarding the vault of the ICL, I would on the other hand prefer to